NachiKet Shankar. His area of keen interest is medical education and research methodology, and he is an active member of the Research Society and Department of Medical Education at St. John's Medical College. Well, does this CV justify his credentials? Probably not. I've known him for several years, and I do know that he's a passionate anatomist. Dr. Lulu has just told us that to be successful, you need to be passionate. So Dr. NachiKet Shankar has been a passionate anatomist and a dedicated medical educationist who has always used innovative teaching, learning, and assessment methods continuously over a period of time. And way back in probably 2010 or 2011, I remember he developed specific learning objectives for the entire dissection manual of Cunningham's when medical education was not that popular in the country. And he published a document on it, which unfortunately was circulated only in Karnataka, and I happened to smuggle it. You probably are not aware of it. So it would be a delight to listen to your insight on innovative teaching, learning, and assessment in competency development, what teachers can do. Over to you, sir.
Thank you, ma'am, for that kind introduction. And I would like to thank the organizers for inviting me for this wonderful conference. And I must say that I don't want to sound flat after the previous inspirational talk. It was really inspirational, and I think I would like to congratulate my humble congratulations to both of you for actually doing training that saves lives. So I think that's wonderful work. So the session that I was given was innovative teaching and learning and assessment activities for competency development. And just a disclaimer, lots and lots of books have been written on innovative teaching, learning, and assessment methods. And in fact, one method per book, there may be multiple volumes for a single method. So the methods that I am going to describe are by no means comprehensive, and I'm sure many of you have a lot of experience and have more methods than what I am going to describe. So this is just based on my experience. Okay, so I like this saying a lot, and I think this is the essence of teaching. I think Dr. Supe sir said that he talked about the 4 roles, and one of them is creativity. And I think we as teachers, our role is to ensure that students and inculcate a spirit of discovery amongst the students. Right? And I think he also put that picture where you have these bright first-year students with stars in their eyes, and once they come out after 4.5 years, they are somewhat cynical and disillusioned. And all they want to do is to crack an exam and do a postgraduate degree. So what we're going to explore during this session is the following. We're going to have a little bit of background to CBME. Again, I think this may be rather unnecessary for most of you, but nonetheless, it will be incomplete without this background. Then I think change drives innovation. So we're going to look at the changes that are required in teaching, learning, and assessment in order to be able to deal with this new curriculum. And we're going to look at innovative teaching, learning methods as well as assessment methods to adapt to these changes. So a little bit of background. I think this is a term that I heard from Dr. Avinash Supe, and I looked it up. And this was an article that was published in the Texas Heart Institute Journal by Herbert Fred in 2005. So I'm just going to read it because I think it rings true to our situation as well. So I'm going to read it out. I call this malady hyposcilia, deficiency of clinical skills. By definition, those afflicted are ill-equipped to render good patient care. Yet, he's talking about the US, of course. Residency training programs across the country are graduating a growing number of these hyposciliacs. Physicians who cannot partake in adequate medical history, cannot perform a reliable physical examination, cannot critically assess the information they gather, cannot create a sound management plan, have little reasoning power, and communicate poorly. Moreover, they rarely spend enough time to know their patients through and through. And I think this was precisely the reason why competency-based curriculum was introduced in India. So I think this all of us can repeat in our sleep. We keep reinforcing this at every medical education workshop, but I think it's important to reinforce this. So once the MBBS graduate comes out of medical college, he or she is expected to be a competent clinician of first contact, a leader of a healthcare team, a communicator with patients, the patient's attenders and the community at large, a lifelong learner, and a professional who practices ethically, right? And it is these endpoints that the competency-based curriculum focuses on, right? The product is this, the Indian medical graduate, and the entire curriculum focuses on this end product. And that's the reason why this competency-based curriculum was introduced. So a little bit about CBME in India. Of course, everything is related to the population health needs, and the competencies were developed in response to the population health needs. And we have the, unfortunately those, okay. So that one was the specific learning objectives. This one was planning the assessment. The third one is the teaching learning methods, and the fourth one was the assessment per se, right? So these were the 4 areas which are related to the competencies. A little bit about the difference between a traditional curriculum and a competency-based curriculum, and it's essential that we understand these differences because all our innovations are related to these changes between the traditional and the competency-based curriculum. So, like we said that in a traditional curriculum, it's all about knowledge, right? Whereas here it's about the application of that knowledge. Coming to the driver of the curriculum, it is, we keep saying it's learner-centered, whereas the driver for the traditional curriculum was basically the teacher. And who's responsible for the content? Here it's joint, the teacher and the student, and not the teacher alone. And a very important point is that there's an emphasis, much more emphasis on formative assessment rather than summative assessment. That is assessment for learning rather than assessment of learning. And the assessment tools are direct observation rather than indirect. That is knowledge, that is you assess knowledge, you assess whether they're able to do things rather than pure knowledge. And the standards are criterion reference, that is if they achieve it, they are deemed to be competent. They are not compared to their peers. And there's variable amount of time, but I think that may not be applicable in the Indian context. Okay, so what are the changes that we need to make in our teaching and learning? So first of all, it all depends on our specific learning objectives. So in the cognitive domain, we need to move from facts to application of those facts, right? So from facts to their application. In the psychomotor domain, we need to move from theoretical knowledge to demonstration. We need to ask our students to demonstrate things and observe that. And in the affective domain, it was hidden before this, and now it's being made explicit. So these are the changes that have occurred as a result of the competency-based curriculum. Now, in order to be able to do this, what do we have to do to our teaching learning methods? Because our specific learning objectives have been changed. And I think this is extremely important. All these 3 have to be in alignment. Our specific learning objectives, our teaching learning methods, and the assessment. And for this section of this presentation, we are going to be focusing on the specific learning objectives and teaching learning methods and their alignment. So, the theory sessions were hitherto passive for the most case. They need to now become active, right? So that's the change that we need to make. And let's look at the methodologies that enable this change to occur. The practical and bedside, rather than becoming theoretical discussions, they need to be demonstrations, and the students need to be able to perform skills under guidance with feedback. Very important. So guidance and feedback are two critical terms. It's not just the performance of skills. We need to ensure that there's guidance and there's feedback that's provided. So this is the small toolkit that we can use for innovative. I would say innovative because we may not have been using it here before, but some of them are already established methods. So coming to each domain, so we have interactive lectures, right? So we can do a lot. These are some of the things that I have done. I'm sure you have done a lot of other things. Using case scenarios in our lectures and asking the why questions. Dr. Avinash talked about the why question, right? That's what encourages creativity and deep thinking and deep learning. So using clinical case scenarios and asking why. Using incomplete handouts, right? So you give the student an incomplete handout and ask them to complete it during the class as the class progresses. There are lovely videos that are available on YouTube and other sources, so we could use those videos during the class. You could use MCQs, and you have things like Socrative, like Kotur sir was mentioning. You can use those tools very effectively in the class, and you can generate interest because you can see how many students got it right and how many students got it wrong, and you get a feedback about how your teaching was. You can even use models, like for example, this was a class that I took on the cervical fascia, right? And this is a simple model where you use some things that are easily available in a stationery store for them to create models in the class. And you can even do role plays, medical theater. So the tools that are available are sort of infinite. It just depends on how creative one is and how much time you have and how much support you have from your department. Next is the flipped classroom. I think this was already mentioned. So basically homework becomes classwork and classwork becomes homework. Traditionally you have a lecture and ask the student to do some exercises post the lecture, which they of course will not do. In a flipped classroom, you give the lectures online or you give them the resources before the class, and the classroom is used for active discussions on that content, right? So it's basically application of content or application of facts rather than the mere reproduction of the facts. So this again is pretty doable. We've tried it out many times, and I'm sure many of you are already doing this. So this is a proven method but you need to select the topics carefully. Mapping, there are two types of maps at least. So one is called a mind map. A mind map is much more colorful. It has a central theme from which radiate out multiple arrows, and you can use different colors. This is basically a mind map of a mind map. So this is something that is very doable in a classroom, and there are excellent online tools, mind mapping tools that are available that students can use. And the other one is the concept map, which is slightly more difficult to do. It starts at the top and branches out, and there are connectors between the bubbles, and those connectors have to be, the students need to use the appropriate words between the connectors. So this is a concept map of a concept map. So it's been shown by some systematic reviews that concept mapping does improve the critical thinking skills of students. Case-based learning can be universally used, and there are many sort of avatars of case-based learning, but broadly these 4 steps are common whenever you can use cases. So there's some prior reading that the student has to do, following which you give them the case scenario in class, and then you brainstorm, maybe ask some questions and they answer, you discuss, and you have active facilitation, right? So this is very doable. I'm sure all of us are doing it, and this is something that's very natural for us as doctors to do, right? So learn around a case, and there are many, many advantages to doing this. However, creating an appropriate case for that student or that group of students is not easy. So I think you need to take some time and develop a good case bank. Team-based learning, again it has a very specific connotation. It was developed originally in management school by Michelson, and it's been adapted very successfully in medical colleges. Again, a systematic review has shown that if not knowledge, at least the students appreciate team-based learning much more than traditional sessions. So it's very structured, so they have to do some reading before class, and then in the class, something very special about TBL is it looks at the readiness of the student to learn. that's incorporated into the TBL process. And once they are ready to learn, they have discussions based around case scenarios, and after that they have in class, they do exercises and so on, and then there is sort of an appeal, there's a peer evaluation. So this is something that you can certainly use. It requires quite a lot of coordination. We use it in St. John's for our linker sessions in the first year. Problem-based learning, as old as started in 1969, McMaster University. It's more than 50 years old, but still I would say it's evergreen in its concept, right? It sort of parallels the self-directed learning cycle that we all follow in our regular routine careers, right? We ask a question, we look for answers, and then we see whether those answers fit in or whether they are correct or not. We evaluate the quality of those answers. So I won't go through this. So these are the steps that the student needs to go through during PBL. And one very nice thing about PBL is usually who decides the learning objectives, teacher or student? Usually in most learning methods, teaching learning, teacher, right? Here it's the students who discuss or who say what learning objectives are for that particular session. This again is pretty doable, and this is one excellent way of improving the self-directedness of students. And this Dr. Avinash Supe already mentioned. There are various ways of improving clinical reasoning, and one of them is the 1-minute preceptor. And again, I think some of the animations are not working, I'm sorry. So basically so this is just to reinforce the fact, from this info, for how many minutes in that 10 minutes does the teacher speak? 1 minute. Okay, that 1-minute preceptor actually takes 10 minutes, but please note that the teacher speaks only for 1 minute. The rest of the time it's the students who are involved. Okay, so again, my intention was not to go through each of the steps. It's just the fact that it's active. And the student is actually involved in this whole process. And please note, 2 important points, there's guidance and there's feedback. 2 critical elements to learning, right? It's not just speaking to the patient and asking random questions, right? It's a very structured process in which there's guidance and feedback. Snaps, again, Dr. Supe already spoke about this. This is another way of encouraging clinical reasoning. So this is the acronym. The students are asked to summarize the patient case which they have taken. Then they narrow down the differential. They analyze the differential. And then they probe the preceptor. Okay, so this is where the interaction between the preceptor and the student occurs. They plan the management, and after that, they're given some self-directed learning to do. They take up some area which is a little hazy, they go back and read about it. Okay, so this again is sort of based around adult learning principles. Okay, so that was some of the ways in which we as medical educators can innovate in terms of the cognitive domain. The psychomotor domain has already been dealt with. There was a workshop that was conducted. I'm sorry for this rather crowded slide, but it's sort of infinite, the things that you can do with simulation. You can use task trainers, you can use human patient simulators, you can use standardized patients, hybrid simulators to add a little bit of realism, right? So for example, you can tie an injection trainer to the arm of a peer and then ask them to first counsel that peer before giving the injection and then give the injection. So not only do you look at affective domain, but also the psychomotor domain. You could look at screen-based simulations, some external screen-based simulations and games are there, medical video games. And now you have, extended reality, you have haptics, you can sort of dissect the liver in the air, right? And you can wear those 3D specs. So sort of the range of simulators that is available is like really tremendous. And for the innovative educator, we can use many of these simulators. Of course, one limiting factor is the cost. So it depends on the amount of infrastructure that your institution has. And this is a very well-known method, and this is something that your students can use when they learn psychomotor skills. Okay, so it's sort of a structure to it. So basically they go through it 4 times. So first they see the instructor demonstrating it quietly. then the instructor narrates the steps while doing it, then the student narrates the steps when the instructor is doing it, and finally the student does it and narrates the steps. So it's like a 4-step process. Now the affective domain, again, I'm not going to go into the detail. There are many tools that you can use. You can use video, sort of video clips, you can use movies, newspaper clips, you can use book reviews, you can use role plays. So it's like huge palette that can be used. But in general, what I'd like to focus on is that students come with already a lot of experiences, right? They're not blank slates. So you need to give them some time to activate their emotions, their thoughts, their experiences. Whenever we look at the affective domain, right? Then we sort of demonstrate or use some sort of like a video clip or whatever, and after that we ask them to apply it using role plays or group discussions, and then of course they integrate it into their routine. So again, we can use this sort of activation, demonstration, application and integration. It's called the Merrill's principles. We can use this in the affective domain. Okay, and what about the time-tested bedside? It's always going to be central to learning in medical education. And I'm not going to go through the steps. This was an article in the Clinical Teacher published in 2021. How to modify the existing bedside to make it more effective. And what they did was they brought in a number of clinicians together and asked them for ideas, the challenges that they face and how to improve bedside teaching. And this is what they came up with. They came up with a 3-stage process. Before the bedside, what can be done? During the bedside, what can be done? And after the bedside. So it is before, during and after. So bedside learning still remains the cornerstone of medical education, but it can certainly be improved by structuring it better. Okay, now let's move our focus to assessment. We've looked at some innovative teaching or innovative ways in which we can use teaching learning methods to develop competencies. Coming to assessment, like I said, we never should forget this, that all 3 need to be in alignment, and we're going to now see some of the assessment methods. I think this, again, it's like already preaching to someone who already knows. We keep repeating this over and over again in medical education, but I think it's extremely important that we have a framework. This is called Miller's Pyramid, and we start off at the lowest level. It's basically the assessment of competencies. So we start off at the nose, which is basically factual recognition. Then we move to the knows-how, which is basically the application of these facts. Shows-how is assessment in controlled conditions, and does is in the workplace. So knows I'm not going to talk about because we've been doing that for many years. So let's see how we can use innovative assessment methods for the other levels. Okay, so a little bit about formative assessment. Like I said, there needs to be much more emphasis on formative assessment in a competency-based curriculum. And for formative assessment, there need to be defined learning outcomes in all domains. Very important, multiple assessment methods. A single assessment method is not enough to assess. Multiple opportunities for gap identification and effective feedback. So all these 4 are essential for formative assessment. Very clear learning outcomes, multiple assessment methods, multiple opportunities for gap identification and effective feedback. Now let's come to the theory assessments. We need to move from recall to application and problem solving. Practical assessments, we need to move from theoretical discussion to observation of performance. I don't know whether it's changed now, but when I did medicine and surgery, my long case was taken not next to the patient, but somewhere in another room. And the only thing that was looked at was the case sheet that I wrote and my answers to the questions. I was very rarely asked to perform a particular test or to actually take the history in front of the examiner, right? So we need to change that. It's not that easy. I know that because there are 30 students and 4 examiners. It's not easy to do, but we need to come up with ways in which we can observe the performance of students during the exams. So here's a little bit, the last few minutes about the assessment toolkit. The knows how, I'm happy to say that we have changed and we have questions like this in our exams now. Just 4 or 5 years ago, this wouldn't have been a question in our question papers. So for example, this is a variant of the question, describe the anatomy of the breast under the following headings, colon, etc., etc. This is the same question, but with the application of facts using clinical case scenarios, right? I think this has come across all subjects, so all of us use it, which is good. The other idea is a structured viva. So viva is one place where there's a lot of bias, right? There's a big variation depending upon whether it's a first student or last student or who the examiner is. So you can have viva cards with different levels of difficulty, and each student, you can have some amount of standardization of the questions that they are asked, including recall and application questions. Shows how, again, you can have OSPI, right? And we have already started doing OSPI. This is an example from anatomy. You can have an OSPI for joint movements and for surface marking. And I'm sure that physiology is already doing it. And we can have OSPI for all the pre and paraclinical departments with a good OSPI bank. And this is an intern's OSCE. At St. John's, we have the intern's OSCE at the end of internship, and some departments have started it as a routine. Then this again, I think for specific skills, it's very good to have OSCEs and make sure that the students gain those skills as they progress through the MBBS course. This is a method called OSLR, Objective Structured Long Examination Review. To keep it simple, it's nothing but a short or long case which is structured. A short or long case which is structured, right? And those of you who are interested can please look it up. It just gives a weightage for history taking, a weightage for examination, and a weightage for the management plan. You can decide as examiners how much weightage to give and what to ask, right? And there's also some amount of case difficulty. Would you agree with me that when I did medicine, for example, my colleague could get a patient with a single system involvement, whereas I could get a patient maybe with 3 systems involved. And I failed because of that, and my friend maybe who's as good as me passes simply because of the case difficulty. The case difficulty was much less. So there's some amount of leeway or there's some amount of weightage given to the difficulty level. So it's basically a structured long or short case, and this is certainly possible. Before we didn't formally assess professionalism. Like I said, now we need to formally assess it. This is what we do in our anatomy department. For example, we look at attendance, we look at punctuality, the level of preparation when they come for the class, how sincere they are, their general behavior. So this is our modest attempt at sort of assessing the professionalism of the students when they come for the dissection. And the holy grail is the workplace-based assessments. This is basically for postgraduates and even faculty, and there are many methods. The important thing is that you can see here, you have the person who's observing, who's probably a senior, and then you have the resident and the patient. This actually happens at the workplace, right? And there are many methods. The more common one is the mini CEX, right? And this is maybe difficult at the UG level, but maybe for interns and postgraduates it is certainly possible. So the basic principles of the workplace-based assessments is in the workplace, it's whole task. It's not compartmentalized like the OSCE and OSPI. There's direct observation, there's a checklist, and there's feedback, right? So all this is there in the workplace-based assessments. And of course, logbooks and portfolios, which we have introduced for our undergraduate students. So a logbook on steroids is portfolio. So the logbook with reflections is basically a portfolio. And the basic principle behind that is reflection. What happened, right? Something would have happened. So you document that. What did I learn from that, right? That's the present. And what next? How am I going to apply that in the future? And I think you'll all agree with me that this results in lifelong learning. And we keep doing that day in and day out, right? We reflect on an experience, we see what we learn and we apply it in the future. And we keep going through that entire cycle. So it's really good if we do that very early in the course, right when they are MBBS students. So we have 2 allies in this. What do you think those allies are? technology, right? So I've not talked about it. So we have a whole host of technologies that can help us to do all the innovative things that we've talked about. And the others? Common refrain is that we have very few teachers, lots of students. So use students, peer-assisted learning. I think that's something that's somewhat unexplored in the Indian context, and it's been proven to be effective. So I think we need to really use and harness the power of peer-assisted learning, and that's really a good field for exploration, I think, in India, because we absolutely have to use it. Otherwise, like in a department like forensic medicine, where there are maybe 2 teachers and 150 students, it's almost impossible to do what we intend to do. So I've come to the end of this talk, and we looked at the background to CBME and what led to the CBME being implemented, and as a result, what changes are required in teaching, learning and assessment, and in order to create those changes or implement those changes, we need innovative teaching, learning methods and assessment methods. So I'd like to end with this. Small actions into lots of people equals big change, and I hope that we all make the small change. Thank you.
So it was a very wonderful and informative session on all the teaching, learning strategies and assessment. I think all of us over here need to implement in our respective fields whatever the methods you have just suggested, and that would be our take-home message. Thank you.
Thank you.
The panel is open for discussion.
I have to congratulate you for a nice presentation.
Thank you, sir.
So, only thing is you have told so many types of assessment and teaching learning method. Only the implementation sometimes I think becomes a problem. And of course you said the peer group assessment. I think we have to go a long way how to actually put into practice. That may be another.
Yes, I think implementation is certainly a challenge, sir. Yes.
What is one change? Yeah, before that, nice talk,
Thank you.
NachiKet, that was very nice. What is one change that you addressed very in detail, the first part of the talk, that is, what is the innovative teaching learning methods, assessment methods we can use? What is the one change we as teachers need to do, or what are the small changes we need to do to make all this happen in real life?
Ma'am, I think like the first talk, sir talked about conation. I think that's the most important thing. So sometimes there's, even Dr. John talks about intention deficit. So I think we need to correct that. And Dr. Lulu also mentioned those 35 trainers, Jiva Raksha, they're passionate about what they do. So therefore it's not very difficult for her to get them together. So I think somehow we need to encourage that conation. So we need to make teachers, it is improving, ma'am, because I think with training, and the spread of the revised basic MET course and the advanced courses, and now there's this conference itself. So every year now there are 4 or 5 conferences on medical education. So I think that critical mass of educators who want to change and who want to be the change makers is coming up. So once that happens, I think that's the most important thing for the change to occur, because we have all the information, we have the training. So I think it's that intention to change. I think that's something that needs to happen first.
I have a comment that I have seen quite often that teachers, they start learning everything. So usually if we just master one technique, because every technique requires a certain backup which has to be developed with a lot of effort. I mean, the questions have to be created, or they have to be placed in certain environment, maybe a Google Drive or somewhere, or a form, or so if we just every teacher focuses on only one method and becomes a master on that, he has more or less achieved his goal.
Yes.
I mean, the problem is in moving horizontally. I mean, if we go more vertically, then it is maybe more practical.
Yes, I think I would agree with you, sir. And also in a particular department, I think, like for example, our department, there may be people who are very good with technology and enjoy it. People who are not so good with technology but who enjoy interacting with students. So I think we need, like you said, sir, so we need to encourage people. We don't have one solution fits all. So maybe we need to encourage faculty and to focus on their strengths, while at the same time having a baseline knowledge about the major techniques that are available. Thank you for that point, sir.
Thank you, sir. I'm here.
Yes, yes.
Yeah. Thank you very much.
Thank
You've covered almost all the different types of teaching, and coming that we have this small group teaching now and less number of faculty, you had talked about peer-assisted learning. What is your experience and what are the drawbacks of it? Because there are a lot of advantages, but any drawbacks?
Okay, ma'am. So there are two parts, ma'am. I'll answer the first part.
Yeah.
So, sort of we have experience, at least personal experience in two areas, ma'am. One is the simulation center. So in the simulation center, usually there's only one teacher and 30 students. And we have only 5 part-task trainers. So there are 6 students around every part-task trainer. And sometimes there's only one facilitator. So what we do is we ask students to rotate roles. So one of them can be the patient, one of them can have the checklist, and one of them can be the doctor or the person who's doing the procedure. And they keep rotating their roles. So in essence, each student is looking at it 3 times from different perspectives. So one is as a doctor, one is as an observer, and one is as a patient. So that's one experience. The second experience is in anatomy. We use osteology, we use peer-assisted learning, where we have the must identify. It's not that difficult. We have the must identify areas of every bone, and the students come together in groups and try and identify that without too much input from the teacher. So we provide the structure, but it's up to the student to discuss and identify the parts of the bone. So those are the 2 experiences that we have. Now the drawbacks are, they call it social loafing. So when groups become large, generally around 1/3 of the students will indulge in social loafing in that they just not take it seriously. But I have realized that if the teacher is vigilant and they can sort of read the body language of the student and maybe break them up into even smaller groups and give them specific tasks and ask them to come back with something back to them in a specified amount of time. So that seems to work. So a little bit of vigilance on the part of the teacher. I wouldn't want to call it monitoring because it has a slightly negative connotation, but a little bit of vigilance I would call it.
Thank you so much, sir. Ma'am, I wanted to answer ma'am's question.
Yes.
So the one change, NachiKet sir and Balu sir and so many of them in St. John's was a change. So we are all PGs from St. John's. So seeing them even in our constrained environment, we do a little bit of their changes in our colleges, whatever we are, to our comfort level, we are trying to implement it. So I think he was a change, so he inspired us, and we would be the next to inspire probably the next generation.
Sorry, very generous of you, Dr. Uma. Sorry, thank you.
Truth, sir.
Thank you, Dr. NachiKet Shankar. That was a quite interactive session.
Ma'am, one question.
Yeah, ma'am, go ahead.
Only one question from me, sorry. Thank you for your stimulating talk, sir. And I'm sure your topic resonates with all Indian medical educators post-2019. Picking a leaf from Dr. Sethuraman's talk in the morning, he mentioned that the current generation has the attention span of a goldfish. He was scientifically correct, because the attention span of a goldfish is around 9 seconds, while a human attention span is around 8. But if I want to go a little lower, I feel the generation Z, this is a practical problem. I feel they have the attention span of a gnat, which is 0. That was said in a lighter vein. But I would like to know, out of all the innovative methods that you have developed, can you name any one innovative method that has worked well with your students?
Yes, ma'am. So I think A couple of things we've managed to publish it. This peer-assisted learning, we've actually shown that it was not a randomized control design, but we have shown that it improves learning. So this peer-assisted learning for osteology is something that we have successfully implemented, and we have shown that it does improve learning.
Thank you, sir. I agree with you because we have developed a peer-assisted learning as well called as Bin Med Mantra, where we get the peers to discuss a case with each other over a period of time, and then they use creative methods to present it after a few days. But then it is time-intensive and resource-intensive. That's the only drawback we found. Thank you once again, sir.
Thank you.
Thank you, sir. Now I request the chairpersons of the scientific session, Dr. Deepthi Shastri and Dr. Vijisha Falgunan, to present the memento to our resource person, Dr. NachiKet Shankar. Thank you, ma'am. Now I'd like to invite Dr. Lakshmi Jatia, Professor and HOD, Department of Physiology, Arpadevidu Medical College, to present the memento to our chairpersons for the scientific session. Dr. Deepthi Shastri. And to Dr. Vijisha Falgunan. Thank you, ma'am. Thank you, Dr. Deepthi Shastri and Dr. Vijisha Falgunan for chairing this session. Here we end up with the scientific session. We'll now request the delegates to join us for the tea. In another 10 minutes, we'll join back here in the Crystal Hall for the award session. Award paper session. I request all the delegates to take this feedback QR code for the date